Good afternoon. First of all, I would like to thank the organizing committee for letting us share with you our work in spinal cord injury patients using cell therapy. In this case, I will present long-term evolution after cellular therapy in spinal cord injury patients. Restoring the connection between the proximal and caudal ends of the spinal cord has been one of the main goals of cell therapy since the late 20th century. In 2002, we started working in this area, and over the years, we developed a therapeutic strategy that combines cell therapy in the spinal cord and skeletal muscles with an intensive and multidisciplinary rehabilitation plan. Here I am presenting long-term follow-up of 13 patients that received at least 2 years of complete treatment. I will start describing the material and methods of this study. Our treatment strategy in chronic and complete spinal cord injury patients is the combination of cell therapy that includes spinal cord therapy and muscle cell therapy, plus rehabilitation. The patients that were included in this study were 8 paraplegic, 5 quadriplegic. All of them had traumatic injury of the spinal cord. All of them were in a chronic stage at the moment they start treatment. All of them were functionally complete ASIA-A spinal cord injury, and at the time they start treatment, they had already received the standard treatment for spinal cord injury. This table tried to reflect the characteristics of the quadriplegic population about age at the beginning of the treatment, sex, years since the spinal cord injury when they start treatment, level injury, and mechanism of injury. And this other table shows the same specificity about the paraplegic population. The cell therapy was using always autologous cells. The stem cells were obtained from fat tissue, and we also combined the stem cells with autologous lymphocytes that we took from peripheral blood. To obtain the neural progenitor cells, we cultured the mesenchymal stem cells from fat tissue, and after we obtained the amount we needed, we combined the mesenchymal stem cells in the lab with effector T cells, effector T lymphocytes that were previously activated with specific antigens derived from a central neural system. So after this combination of these 2 types of cells in the lab, we obtained the neural progenitor cells that were implanted in the patient. Neural effector T lymphocytes were obtained after the activation of peripheral lymphocytes that were cultured in the presence of cerebral lesion. To apply the stem cell cell therapy in the spinal cord, we did it in two steps. First, we infuse by intravenous infusion effector T lymphocytes. The objective of this was to open the brain-blood barrier around the site of the lesion, generating a very specific inflammation around the scar with the lymphocytes. 48 hours later, by artery infusion, we implant the neural progenitor cells with also effector T lymphocytes, with the objective of replacing the lack of cells in the damaged spinal cord. To obtain muscular progenitor cells, we also use the combination of mesenchymal stem cells derived from fat tissue and specific lymphocytes. But in this case, to activate the lymphocytes, we use a different antigen. In this case, we use specific peptides derived from muscular tissue. And after the co-culture of mesenchymal stem cells and these specific lymphocytes, we obtain the muscular progenitor cells. To implant the cells in the muscular tissue, we use the ultrasound guide. So we choose the muscles that show signs of atrophy, and by the ultrasound we were sure that we were implanting the cells into the muscular tissue. In this case, we also implant the muscular progenitor cells with the combination of the effector T lymphocytes. In this slide, we show the timetable treatment. As you can see, during the 2 years of treatment, patients receive 4 times cells in the spinal cord with 6 months in between each implant, and 12 times cells in the specific muscles with 3 months in between each implant. About the rehabilitation program, it includes at least 25 hours per week. Patients were trained to regain functions such as standing, trunk control, and gait. In the program, we also stimulate the isolated movements of areas that were previously damaged because of the lesion. We work a lot with the respiratory automatisms. We also stimulate the sensitivity functions such as proprioception and deep sensitivity. And the main objective was that the patients must learn again how to generate the movements and understand the sensitivity stimulus. Both cell therapy and the rehabilitation program were well tolerated without any significant side adverse effects. We saw electromyographical record recovery. In this case, as an example, you can see the tibialis anterior muscle and the electrical activity in a T8 patient. In the first one, you can see no electrical activity after we ask her to move the foot. And in the second film, you can see that when we ask her to move the foot, even though there is no specific movement, each time she tries, there is a change in the electrical activity of the muscle. So we saw these changes in different muscles of every patient that had no activity related with voluntary action before the treatment, and after the first 6 months, they show these signs of electrical activity after we ask the patients to try to generate the movement. We also were able to see trophic change in the muscles that received the implants. And in this slide, I would like to show you the ultrasound imaging of a muscle that showed severe signs of atrophy with the correlation of the biopsy of this muscle. And after the implants in these skeletal muscles, we start visualizing this black area that is surrounded, and we also perform a biopsy of this black area, and we were able to see that the tissue showed signs of normal skeletal muscle. So there were signs of recovery of trophism in the muscles that were implanted. About motor recovery and functional recovery of these patients. This table tries to resume the recovery in posture control, trunk balance, global movements as the gait implies, and individual movements of muscles that showed no signs of movements before the treatment and recover movement after the treatment. In this case, I want to show you the example of how the patient achieved the standing position. The two first patients are absolutely standing by themselves without any external support and using these short orthosis. And they were also able to acquire much more trunk stability that led them functions like the using of the wheelchair and be sitting with minimal external support. This video tries to show you the gait process recovery of this patient. He was a C5 patient. He had 5 years of evolution before he started treatment. And as you can see in the film, when we just started working with the gait process, he needed a lot of help. And now he is able to walk by himself, maintaining the trunk stability and giving step by step by himself. Also, as an example, there are some of the paraplegic patients with different kind of gait recovery and stage. And as you can see, they are not overusing the arms as an example of individual movements recovery. This is a paraplegic patient. In this case, she was a flaccid paralysis, a very severe injury that had no movements, no reflex, and the muscles showed severe signs of atrophy below the lesion. In the first film, you can see the first evaluation before the treatment. And these are the different treatment movements she recovered after the cell treatment and the rehab program. What happened after 2 years? This patient finished treatment. And we were able to do this because we had to stop treating them in the beginning of 2019. So we kept the clinical periodic evaluation of this patient, but we were not able to treat them as we were treating with the cells in the rehab program. What we found was that the functions they had gained stayed. If a patient gained the possibility to be in the standing position by himself, he maintained that possibility over the time, even though he wasn't receiving the physical stimulation that the neurorehabilitation programs was given to him. So we were very surprised. And as an example, I want to show you 2 patients that also kept improving over these 2 last years. In this case is the T12 patient, and as you can see, she improved the gait, being able to use a walker machine. She also gained the possibility to move the legs by herself with a biking, and she also maintained the possibility to be standing by herself with the use of a cane. The other example I wanted to show you was this C5 patient that maintained the trunk stability and strength. He kept working in his house by himself, and this is 2 years after he received the last cell treatment. And he also maintained the possibility to be standing by himself. And this situation was repeated in every patient of this cohort. So our conclusion is that combined treatment is well tolerated, that to achieve significant improvement with this treatment, you require, in the beginning, time. This is a long-term treatment. You also require, because of the severity of the lesion, several cell implants, and you have to work with both the spinal cord and the skeletal muscles. And you must combine the cells with the physical stimulation. And at the very beginning, you have to be very strict, and the patient must learn again these functions. But once they learn and they achieve the function, then it stays over the time.